Have you ever wondered what happens to a medical breakthrough after it finally leaves the pristine, highly controlled environment of a clinical trial and actually enters the messy real world?
Oh, yeah. It's a huge transition.
Right. Because for you listening, we constantly hear about these miracle treatments in the news. But the patients in those initial studies, I mean, they are meticulously handpicked.
Very heavily screened. Yeah.
Exactly. And they're monitored around the clock by these elite teams of researchers. The entire environment is practically bubble wrapped to ensure that literally nothing interferes with the data.
It is a highly curated reality, but, by design. When you are introducing a brand new medical device into the human body, you absolutely have to prove it works safely under ideal conditions first.
Right, the textbook scenario.
Exactly. But the ultimate test of any medical innovation isn't how it performs in that textbook scenario with unlimited resources. The real test is, well, how it performs on a random Tuesday afternoon in a busy community hospital being handled by a doctor who is juggling 30 other patients.
And for you listening, that transition from the laboratory to the local hospital is exactly what our deep dive into the source material is focused on today.
It's some really fresh data, too.
Yeah, it is. We are looking at a massive, brand new analysis from the STSC-CC-TVT registry. And for those who don't spend their weekends casually reading cardiovascular journals.
Which is most people, let's be honest.
Well, fair enough. That stands for the Society of Thoracic Surgeons and the American College of Cardiology Transcatheter Valve Therapy Registry. It's essentially the gold standard, right?
Yeah, it's a massive national database where specialists track these specific procedures across the U.S. to see what actually happens to everyday patients.
And the specific procedure this registry data is tracking is called Transcatheter Tricuspid Valve Replacement, or TTVR.
Right, and the timeline we are looking at here is incredibly vital. This statistical analysis was literally just completed in February 2026, and it looks at every single one of these patients treated across the U.S. between February 2024 and March 2025.
Okay, let's unpack this. To give you all some context on the timeline, the TRISCEND II randomized clinical trial is what originally proved this procedure was actually superior to just giving patients medication.
Which was the old standard of care.
Right. And that clinical trial led directly to the U.S. regulatory approval of TTVR back in 2024. But once that approval happened, the gates basically opened.
The device was officially out in the wild.
Exactly. Clinical trials are like a highly supervised laboratory experiment, but a Tuesday afternoon in a busy community hospital is a totally different beast. So we are setting out to see if the hype survived contact with reality.
It's the million-dollar question. When everyday hospitals start using this really complex device on everyday patients, do the numbers actually hold up?
But this raises an important question right from the start about the patients themselves. Because before we can even look at the success rates of the procedure, we have to deeply understand exactly who is lying on that operating table.
Yeah, because if we don't understand the severity of their condition, the subsequent data just won't carry its true weight.
So the source tells us these patients were suffering from symptomatic severe tricuspid regurgitation, which the medical community shortens to TR.
Right, TR.
And the tricuspid valve acts like it's like a one-way door between the two right chambers of the heart. When you have severe regurgitation, that door is essentially broken. It's just flapping open.
Yeah, it's not sealing at all.
So instead of moving forward into the lungs, blood flows backward with every single heartbeat.
And the mechanical failure of that valve creates just a devastating domino effect throughout the body.
Because of the pressure, right.
Exactly. Because the blood is flowing backward, pressure builds up in the venous system. Fluid starts to pool in places it absolutely shouldn't be.
Like where?
Well, patients experience profound swelling in their legs and their abdomen. Their liver becomes congested and enlarged. They lose their appetite. Their kidneys start to really struggle. And they are just constantly overwhelmingly exhausted.
And the crucial phrase I noticed in the text is that these patients were suffering from all of this despite being on optimal medical therapy.
That is key.
Meaning their doctors had already thrown the absolute kitchen sink at them pharmaceutically.
Oh, completely. They were on massive doses of diuretics, trying to literally force the kidneys to flush out the excess fluid, and it just wasn't working anymore.
The mechanical problem was just overpowering the chemical solutions.
Yeah. Until TTVR came along, these patients were essentially trapped in a downward spiral. The text explicitly notes that TTVR was only performed after a dedicated heart team deemed it appropriate.
A heart team being?
It's a multidisciplinary group.
Mm.
Surgeons, cardiologists, imaging specialists who review a case to ensure there are absolutely no other viable options. I mean, these are not people coming into the clinic for a routine tune-up.
Right. When I look at the demographics pulled from this registry data, the thing that screams at me is the sheer frailty of this group.
It's sobering.
Yeah. There were 1,034 attempted procedures tracked across 82 different centers in the U.S. The average age was 77.1 years old, and almost 70% were female.
We are talking about an older, highly comorbid population with bodies that have already been through a whole lot.
Right. And the metric that truly quantifies their daily struggle is the NYHA functional class.
Yeah, the registry shows that 73.2% of these patients were in NYHA class 3 or 5.
Which is high.
Very high. The New York Heart Association functional classification is the gold standard cardiologists use to measure how much heart failure limits a patient's physical activity.
For you listening, imagine trying to run a marathon while breathing through a cocktail straw. That is how these patients feel just trying to walk across their own living room.
It's a great analogy.
Class 3 means you might be okay sitting on the couch, but simply getting up to make the bed or, walk to the bathroom causes extreme fatigue, palpitations, or shortness of breath.
And class 4 is the absolute extreme. It means you have those heart failure symptoms even while sitting perfectly still in a chair.
So operating on someone in that condition is incredibly perilous.
Oh, absolutely. Because they are 77 years old on average, with multiple other health issues and failing organs from the fluid backup, traditional open-heart surgery is often completely off the table.
Because it's just too much trauma for the body.
Exactly. Cracking the chest, stopping the heart, and putting them on a bypass machine carries a mortality risk that is simply way too high.
Which brings us to the marvel of the transcatheter part of TTVR. Instead of opening the chest, it is essentially like a master mechanic swapping out a crucial engine valve through the tailpipe without ever having to unlatch the hood.
That's essentially what it is, yeah.
They thread the brand new artificial valve up through a blood vessel, usually starting down in the leg, right?
Yeah, usually the femoral vein.
Right. And they navigate that delivery system all the way up into the beating heart, position it inside the failing tricuspid valve, and deploy it while the heart is still actively pumping.
The physical execution required to achieve that is frankly mind-bending. The tricuspid valve is notoriously difficult to image and navigate. Doing this in a highly monitored trial with the world's leading experts operating the catheter is one incredible achievement.
But doing it in the real world.
Right. Rolling it out to 82 different medical centers across the country with local hospital teams taking the reins is another universe entirely.
So what does this all mean? Did the real-world application actually work? When these 82 centers took on this monumental task, did they fix the mechanical problem? And more importantly, did they give these patients their lives back?
Well, the procedural success rate reported in the registry data is staggering. Out of those 1,034 attempted procedures on frail, elderly patients, a valve was successfully implanted in 1,017 of them.
Wow.
Yeah. That is a 98.4% success rate.
Taking a brand new, highly complex cardiac device, putting it into the hands of real-world operators, and seeing a 98.4% success rate is almost unheard of. But getting the device into the heart is only half the battle.
Right. Did it actually seal the leak?
Exactly.
Well, the data answers that definitively. Mild or less TR, meaning the backward flow of blood was virtually entirely eliminated, was achieved in 98.4% of patients immediately after the procedure.
So it basically worked perfectly right out of the gate.
Yes, and just to prove it wasn't a temporary fix, that number held incredibly steady at 97.7% at the 30-day mark. The real-world operators achieved near-complete elimination of the disease mechanics. They sealed the door.
But, it's one thing for a doctor to look at an echocardiogram monitor and say, the new valve looks great. A 98.4% technical success rate is a fantastic statistic for a hospital's marketing brochure.
Oh, for sure.
But as a patient, you don't care about the image on a screen. You care about whether you can walk down your driveway again. The text highlights health status outcomes, specifically something called the KCCQ-OS score, which jumped an average of 22.4 points.
What's fascinating here is that the KCCQ-OS, the Kansas City Cardiomyopathy Questionnaire Overall Summary, is arguably the single most important metric to the patients themselves.
Why is that?
Because it's not a blood test. It's not a lab value. It's a highly specific, extensive survey that asks the patient directly about their quality of life.
Like what kind of questions?
It asks things like, Over the past 2 weeks, how much has your heart failure limited your ability to shower or dress yourself? Can you sleep lying flat without waking up gasping for air? Can you walk a block without having to stop and rest?
Okay, so a 22.4-point jump sounds significant on paper. But for someone living with this disease, how does that actually translate to their day-to-day reality?
To give you the clinical perspective, a 5-point improvement on this questionnaire is considered clinically significant.
Just 5 points.
Just 5 points. That means the patient notices a tangible difference in their life. A 10-point jump is considered a moderate to large improvement.
Oh, wow.
So to see a mean increase of over 22 points across this entire cohort is transformative. The data is so overwhelmingly tight here that we can completely rule out any sort of placebo effect or statistical fluke.
That's incredible.
It is a mathematical certainty that this device dramatically altered their physical capabilities. It means the vast majority of these people are reclaiming their independence.
Which lines up beautifully with the other functional statistic provided in the source. By the 30-day follow-up mark, 82.7% of the patients had improved to NYHA functional class 1 or 2.
Which is a massive shift.
Yeah, remember, nearly 3/4 of them started in class 3 or 4, struggling to breathe while just sitting down. Just 30 days later, over 80% of them are able to go about normal daily activities with minimal or zero symptoms.
If we connect this to the bigger picture, heart failure is a notoriously progressive, relentless, downward trending disease.
It usually only goes one way.
Right. To take a 77-year-old whose heart is structurally failing and mechanically reverse their symptoms to that extreme degree in a single month is a profound validation of transcatheter technology.
There is always a caveat in medicine, though. Improving a patient's quality of life from a state of total exhaustion to living independently has to come with risks, especially given their baseline frailty.
There's no free lunch in cardiology.
Exactly. We have to look at the physical toll of getting there. What are the safety risks of threading a massive artificial valve into the heart of a 77-year-old in a real-world hospital setting?
The registry data meticulously tracked the 30-day event rates to answer exactly that, and the numbers show an exceptionally acceptable safety profile.
What were the rates?
All-cause mortality at 30 days was 3.1%. The stroke rate was 0.2%. Heart failure hospitalizations were at 3.1%, and bleeding events sat at 7.9%.
Let's contextualize those numbers, because just hearing a list of percentages can kind of wash right over you.
Yeah, it's easy to lose the impact.
Normally, when you are threading large catheters through the vascular system of an elderly patient, navigating past decades of potential plaque buildup, the risk of knocking something loose and causing a stroke is a massive looming fear.
It's one of the biggest fears.
So the idea that the stroke rate was 0.2% in 30 days seems almost impossibly low for this demographic.
It is an incredible achievement in procedural safety. The 3.1% mortality rate also needs to be viewed through the lens of their condition.
How so?
Well, without intervention, patients with severe symptomatic tricuspid regurgitation face dismal survival rates. The fact that nearly 97% of these highly vulnerable patients survived the 30-day window, with the vast majority experiencing massive symptom relief, is just a testament to how minimally invasive this approach truly is.
But the procedure isn't without its unique complications.
No, it's not.
The source explicitly points out the data on CID implantation. It notes that new cardiac implantable electronic devices were required in 15.9% of patients who didn't already have one.
Right.
I know a CID is usually a pacemaker, but why would fixing a mechanical valve suddenly require an electrical intervention? Like, those seem like two totally different systems.
They do, but to understand the mechanism behind that, you really have to picture the anatomy of the heart. The heart has its own internal electrical wiring system that tells the muscle when to contract. One of the main electrical junction boxes, called the AV node, sits extremely close to the annulus, the outer ring of the tricuspid valve.
So they're right next door to each other.
Exactly. When doctors implant a new artificial valve inside the old one, the metal frame of the new valve expands outward to anchor itself in place.
Oh, I see where this is going.
Yeah. If that radial force pushes too hard against the heart tissue, it can physically compress or damage those nearby electrical pathways. The signal from the top of the heart gets blocked before it reaches the bottom.
Wow.
When that happens, the patient needs a pacemaker implanted to take over and keep their heart rhythm steady. So roughly 16% of the patients who were completely pacemaker naive ended up needing one to fix that electrical disruption.
That makes perfect mechanical sense. But the study also conducted a subgroup analysis, specifically looking at patients who already had a pacemaker or a similar device at baseline.
This is one of the coolest parts of the data.
Yeah, and the data claims there was absolutely no significant difference in their outcomes. Intuitively, that sounds so counterintuitive.
It does.
You are jamming a large, expanding metal frame into a space that already has pacemaker wires, or leads, running directly through it. How does that not cause massive complications?
Yeah.
How are they not just crushing those existing wires?
This raises an important question, and honestly, the fear of crushing those existing pacemaker leads was actually a major theoretical concern in the cardiology community before we had this real-world data.
Because they have to pass right through the valve, right?
Yes, the tricuspid valve is the very door those wires pass through to get to the bottom of the heart. The assumption was that pinning those wires against the heart wall with a new heavy metal valve would damage the wires or cause severe structural damage to the heart itself.
But it didn't.
It didn't. The registry data showed that having a baseline CIE made absolute zero difference in 30-day mortality, heart failure hospitalization rates, or functional outcomes.
That is wild.
It provided ironclad proof that the baseline device had no negative impact. The operators were somehow able to deploy the valve without compromising the existing electrical hardware.
But here's where it gets really interesting.
Yeah.
Usually when a complex treatment leaves the perfect, bubble-wrapped world of clinical trials, complication rates go up.
Because it's messier out here.
Right. You no longer have the hand-picked, world-renowned experts performing the surgery, and you have a much wider, much sicker variety of patients coming through the hospital doors.
True.
But the text explicitly notes that bleeding and new CIE rates were actually lower in this real-world registry than they were in the Transcatheter Tricuspid clinical trial.
Yeah.
How is it possible that the messy real world is actually outperforming the pristine clinical trial?
That is undeniably the most striking takeaway from this entire analysis. It is highly unusual to see safety profiles improve when a device goes to the broader market.
So what's the secret?
It all comes down to the mechanism of the medical learning curve. When the Transcatheter II trial was happening, the device was entirely brand new. The operators, even the elite ones, were learning the nuances of the tricuspid anatomy and how the device behaved on the fly.
They were the guinea pigs, in a way.
Exactly. By the time this real-world registry data was collected, starting in February 2024, the broader medical community had the immense benefit of learning from every single challenge faced during the trial.
So they weren't just repeating the trial, they had reverse engineered the complications and actively improved the procedure.
Yes. They figured out the exact mechanisms to avoid those early pitfalls.
Like how?
Well, take the pacemaker issue, for example. The operators learned how to utilize advanced 3D imaging, like CT scans and transesophageal echocardiograms, to perfectly size the artificial valve before the patient even entered the operating room.
Oh, so they knew exactly how much it would expand.
Right. They learned how to deploy the valve slightly higher or lower to just completely avoid pinching the AV node. They refined their maneuvering techniques to navigate around existing pacemaker wires.
And what about the bleeding?
They even improved their protocols for managing blood thinners post-op, which directly explains the drop in bleeding complications.
It is a phenomenal testament to how rapidly the medical community can share knowledge and optimize a technique. The real-world doctors essentially stood on the shoulders of the clinical trial pioneers, mapped out the danger zones, and just perfected the execution.
This unexpected drop in complication rates compared to the initial trials is really the ultimate validation of the procedure's real-world viability.
Yep.
It proves that transcatheter tricuspid valve replacement isn't just some miraculous party trick that only a handful of elite surgeons can pull off in $1 million laboratory.
It's scalable.
It is a highly reproducible, standardizable procedure that can be safely taught to operators across dozens of centers, resulting in consistently excellent outcomes for everyday patients.
It really paints a phenomenal picture for the future of heart care. If we zoom out and distill the key takeaways from this source for you, the listener, the narrative is crystal clear. The early U.S. real-world experience confirms, without a shadow of a doubt, that TTVR is a remarkably safe and highly effective treatment for severe tricuspid regurgitation.
It mechanically eliminates the regurgitation, boasting a nearly 98% success rate at 30 days. It seals the leak and completely stops the devastating backward flow of blood.
It vastly improves the quality of life, jumping patients up a massive 22 points on the KCCQ-OS scale.
Which is huge.
Yeah, it takes an older, vulnerable population who couldn't walk across a room without gasping for air and hands them their independence back.
And perhaps most significantly for the medical community at large, it boasts complication rates that are impressively lower than even the initial randomized trials predicted.
Proving the power of the clinical learning curve.
That's
We are so incredibly used to seeing medical treatments overpromise in the pristine, controlled environment of the lab, only to drastically underdeliver when they hit reality.
It happens all the time.
But if this national registry data shows us that a massively complex device like a transcatheter heart valve can actually perform better and safer out in the messy real world, what does that mean for how we evaluate future medical technologies?
That's a great question.
What other life-saving innovations might currently be trapped in a lab, viewed as too complex or too risky, just waiting for the chance to prove exactly how effective they can be in the wild?